Ich zeige Subscapularis muscle, access and treatment from lateral. Before we start this treatment, let's see what parts of the subscapularis muscle may be affected by examining the external rotation in the shoulder joint in various abduction positions. If the patient in this position feels the pain known to him, and there is a movement restriction, and the range of motion is free and without pain in these positions, then this is a sign that in this position the transverse fibers of the subscapularis muscle are most stretched. And with that I have a focus, and I know that in the manual treatment I will have to look for these transverse fibers. In contrast, when it is easy in this position and the patient says, in the high rotation, now it is painful, then this is a sign that the laterally located diagonal fibers are slightly stretched by the abduction, and now through external rotation, these diagonal fibers are mainly affected. When this is clarified, I ask the patient to lie diagonally on the bed and to come with the shoulder to the edge of the bed close to me. I choose a grip that I can push the acromion caudally with my elbow here, and with the other hand I palpate the thorax, the ribs, and then slightly laterally I feel the lateral border of the scapula, so that I can push the scapula cranially with my left hand and caudally with the right elbow. Elevation, depression. With this grip version I can carry out also an anteversion, a retroversion, and thus test the mobility of the scapulothoracic gliding space. And I can move the arm in internal and external rotation. Thence the main component for the subscapularis muscle is the internal rotation. When I am positioned like this, I go first between the thorax and the border of the scapula in the depth. And try, as technique 4, to open the scapulothoracic gliding space here. Before I do it stronger, it is important that, in order not to hurt the patient, I use some massage cream in this area to have the gliding space as slippery as possible. So I take some massage cream to be able to achieve optimum lubricity here. I find my position again with my right hand and my right elbow. The left hand goes into the gliding space. Via depression, elevation, I am working slowly into the depth. I inform the patient that this can often be a very painful treatment. And through eye contact with the patient, I constantly check if there are any nonverbal signals indicating that it may be too intense, and then I would encourage the patient to say stop. So I advance step by step with technique 4, fascial separation, between the subscapularis muscle and the serratus anterior muscle in the scapulothoracic gliding space. I explore all angles and corners. Here, now it is painful as I see the patient's mimic reaction. Now it is very painful. Then I reduce the pressure and see that it is possible to bear it. And now I move the subscapularis muscle via rotation in this area. I dose that the tension stays low, even if it hurts. The primary axis is thus via technique 4, fascial separation technique, and often the main problem is an adhesion between the fascias of the serratus anterior and the subscapularis muscles. As soon as I carry out the technique 4 here, and I arrive in the depth, I can tilt my fingers, and by tilting to the technique 4 is added the technique 1 or 2. Please let me know if it hurts too much. Now I'm in the scapulothoracic gliding space, and I would ask the patient, do you know the pain? And if the patient did say yes, I would carry out the technique 1 here, or the technique 2b. Moving here would be technique 2b. Okay. In this approach, the therapist sits. Then, the therapist can choose a second approach while standing, a second setting, by holding with his hand the patient's shoulder. The spina and the medial border of the scapula, so that I can carry out anteversion and retroversion, anteversion, retroversion, and mobilize the scapulothoracic gliding space. If that works, I take my fingers and place them in the gliding space between the thorax and the scapula. Now we are gliding dorsally, both with the scapula and with my right hand, as well as with the fingers of my left hand. The fingers of my left hand now remain stationary, and now I pull the scapula with my right hand over the fingers of my left hand. And by doing so, I slide deeper into the gap between the serratus anterior and subscapularis muscles. Then all three, right hand, scapula, and fingers of the left hand, move dorsally. The fingers of the left hand remain in place, and with the right hand I pull the scapula anteriorly over the fingers of the left hand, and go to the pain threshold of the patient. Through eye contact, I see if that's okay or too much. And I repeat that 3 or 4 times. Technique 4. Now a third setting for the lateral approach to the subscapularis muscle. Please take place in the middle of the bed and put your hand to the neck. Most shoulder patients appreciate if you underpin the elbow here. And in this setting, I can now treat the fibers of the subscapularis muscles where they come out of hiding at the lateral border of the scapula and lead to the lesser tubercle of the humerus, where I can treat them here without problems. That is always possible, even if the accesses I showed earlier to read the hidden parts of the subscapularis muscles are not possible. You can always reach this part of the subscapularis muscle here. Examine, and if trigger points are present, treat. This is now with technique 2A. The subscapularis muscle does not allow to carry out technique 3. We have no access. We complete the treatment with a mobilization of the scapulothoracic gliding space. So we mobilize the gliding layers here by anteversion, retroversion, and elevation, depression. And so we conclude the treatment of the subscapularis muscle here with a non-painful treatment sequence.